Unit 8, Anxiety Disorders. 8.2 Introduction. We often become anxious in our day-to-day life situations, such as, when we have to appear for an exam/job interview, or caught in a traffic jam while already running late, trying to meet the deadlines, etc. Our level of anxiety decreases once we come out of such situations. However, it is important to look at certain situations when the individual remains anxious irrespective of the situation and is unable to cope with it. When this happens, the person is said to be suffering from anxiety disorder/S. There are several anxiety disorders that have been identified by DSM-5, like generalized anxiety disorder, specific phobia, social phobia, panic disorder, and agoraphobia. But before we delve further into these disorders, let us first understand about anxiety and other similar conditions such as fear and panic. Distinction between anxiety, fear, and panic. The most common way to distinguish fear and anxiety has been in the terms of an actual external stimulus that is perceived as a real danger/threat by most people. Fear is experienced in the presence of real danger/threat, whereas anxiety is experienced only in anticipation of danger/threat when such a danger/threat is not present or cannot be specified. Several researchers have distinguished between fear, panic, and anxiety in terms of cognitive/subjective, physiological, and behavioral components. These components are loosely associated, i.e., every individual may not necessarily experience all the three components. Thus, someone having fear or anxiety may experience cognitive and physiological component with greater intensity than the behavioral component and vice versa. Panic, like fear, has all the above three components. However, additionally, panic attack is characterized by subjective feelings of impending doom, fear of dying, going crazy and losing control. Anxiety, on the other hand, is a more diffused, future-oriented state that comprises of a complex blend of cognitions and emotions. It needs to be noted here that all of us experience fear, anxiety and feelings of panic sometime or the other. However, these become causes of concern when these are intense, persistent, interfere in our daily functioning, negatively affect our adjustment in different aspects of our life, and impact our health and well-being. In these cases, it becomes a mental health condition and disorder to be treated by mental health professionals. Socio-cultural context needs to be taken into account by the healthcare workers while treating, as it plays a significant role in influencing the manifestation, progression and intervention in case of anxiety disorders. However, more research needs to be done in exploring the effectiveness of context-specific techniques and interventions for dealing with anxiety disorder. As studies indicate, there is lack of research in India with regard to epidemiology, phenomenology, cause, outcome, and management of anxiety disorder. 8.3 Phobia, Clinical Features, Causes and Treatment. Clinical features. A phobia is a persistent and disproportionate fear of a specific object or situation that presents little or no actual danger to a person. DSM-5 has identified three categories of phobias: specific phobia, social phobia and agoraphobia. Now, we will discuss the above-mentioned phobias separately. 1. Specific phobias. Specific phobia is diagnosed when a person shows strong and persistent fear which is triggered by a specific object or situation. On encountering a phobic stimulus, the person with specific phobia show an immediate fear response that resembles a panic attack except for the presence of a clear external trigger. They experience anxiety on anticipation of the phobic stimulus and go to great lengths to avoid it. The person is fearful and avoids even the mere representations, picture/model, of the phobic stimulus. Most often, the person has an insight about one's condition, that is, the person recognizes that the response to a phobic stimulus is unreasonable or excessive. Box 8.1 Criteria for specific phobia according to DSM-5. A marked and persistent fear that is excessive or unreasonable, cued by the presence or anticipation of a specific object or situation, for example, flying, heights, animals, receiving an injection, seeing blood. B. Exposure to the phobic stimulus almost invariably provokes an immediate anxiety response, which may take the form of a situationally bound or situationally predisposed panic attack. Note: in children, the anxiety may be expressed by crying, tantrums, freezing, or clinging. C. The person recognizes that the fear is excessive or unreasonable. Note: in children, this feature may be absent. D. The phobic situation, S, is avoided or else is endured with intense anxiety or distress. E. The avoidance, anxious anticipation, or distress in the feared situation, S, interferes significantly with the person's normal routine, occupational, or academic, functioning, or social activities or relationships, or there is marked distress about having the phobia. F. In individuals under age 18 years, the duration is at least 6 months. G. The anxiety, panic attacks, or phobic avoidance associated with the specific object or situation are not better accounted for by another mental disorder, such as obsessive-compulsive disorder, for example, fear of dirt in someone with an obsession about contamination, post-traumatic stress disorder, for example, avoidance of stimuli associated with a severe stressor, separation anxiety disorder, for example, avoidance of school, social phobia, for example, avoidance of social situations because of fear of embarrassment, panic disorder with agoraphobia, or agoraphobia without history of panic disorder. DSM-5 defines 5 types of specific phobias. Animal. These include fears of animals such as dogs, cats, spiders, bugs, mice, rats, birds, fish, and snakes. Natural environment. These include fears of heights, storms, and being near water. Blood injection injury. These include fears of seeing blood, receiving a blood test or injection, watching medical procedures on television, and for some individuals, even just talking about medical procedures. Situational. These include fears of situations such as driving, flying, elevators, tunnels, and enclosed places. Others. These include other specific fears, including fears of choking or vomiting after eating certain foods, fears of balloons breaking or other loud sounds, or fears of clowns, or space phobia where the person has a fear of falling down if he/she is away from walls or support. 2. Social phobia is a fear of social situations. A person is afraid of acting in a humiliating or embarrassing way when he/she is exposed to the scrutiny of others. Social phobia may be specific to a situation such as fear of public speaking or generalized as in fear of many different social interactions. 3. Agoraphobia was traditionally thought to be a fear of agora, Greek word for public places of assembly. Thus it is a fear of being in a public place or crowded places such as shopping malls, theaters etc. where there can be large gatherings. It mainly involves a fear of having a panic attack in situations where escape might prove to be difficult or embarrassing. Comorbidity. People who suffer from specific phobia are likely to suffer from other anxiety disorders also. Prevalence, age of onset, and gender differences. Lifetime prevalence for specific phobias is 12%, which implies that these phobias are quite common. In India, however, prevalence rate has been reported to be 4.2%, which is significantly lower as compared to other countries. Despite being very common, people with specific phobias are less likely to seek treatment than people with other anxiety disorders. The most common specific phobias are fears of spiders, snakes, and heights. Phobias also depend on culture. For example, in China, Peiling is a fear of cold, in which the person fears that loss of body heat may be life-threatening. The age of onset for specific phobias varies depending on the fear. Animal phobias, storm phobias, blood injection injury phobias and dental phobias typically begin in early childhood. The average age of onset for height phobias is in the teens, whereas specific phobias of enclosed places, claustrophobia, and driving phobia often begin in adolescence and early adulthood. Some specific phobias, for example, spiders, storms, are much more common among women than men, whereas others, for example, blood phobias, are equally found in men and women. Lifetime prevalence is about 7% for men and 16% for women. General characteristics of people with phobias. People with phobias usually know that their fears are somewhat irrational, but they cannot help themselves. If they attempt to approach the phobic situation, they are overcome with fear or anxiety, which may vary from mild feelings of apprehension and distress to a full-fledged activation of the fight or flight response very similar to panic attack. Phobic behavior tends to be reinforced by the reduction in anxiety that occurs each time a feared situation is avoided, and phobias may sometimes be maintained by secondary gains, such as increased attention, sympathy, and some control over the behavior of others. These benefits are usually not in awareness of the sufferer. Causes of phobia. The causes of specific phobias are complex, involving biological factors, a history of negative experiences in the feared situation as well as other psychological factors, and evolutionary factors. 1. Biological perspective. Genetic factors. The speed and strength of conditioning of fear is determined by genetic and temperamental. This means that phobias are acquired as a result of genetic makeup or temperament and personality. People who are carriers of one of the two variants on the serotonin transporter gene, which is linked to high neuroticism, are more likely to be conditioned to fear stimuli. Related to these findings, Kigan et al. Reported that behaviorally inhibited, shy, timid toddlers showed a higher risk for the development of multiple specific phobias at 7 to 8 years of age than were uninhibited toddlers. Studies have also indicated a modest genetic contribution. For example, Fire et al. Reported an elevated risk of specific phobias in first-degree relatives of those who had been diagnosed with specific phobia. Twin studies on females and males found a higher concordance rate for animal phobias in MZ than DZ twins. The same studies have also reported the effect of the non-shared environment on the origin of specific phobias, which implies the role of other factors, such as psychological and socio-cultural, in the acquisition of specific phobias. 2. Psychological perspective. Psychoanalytic viewpoint. According to Freud, phobias represent a defense against anxiety that stems from repressed impulses of the ID. As it is too dangerous to know the repressed ID impulse, the anxiety is displaced, defense mechanism, displacement, onto an external object or situation that has some symbolic relationship to the feared object. Freud explained the development of phobia with the case study of little Hans, a 5-year-old boy with a phobia of horses. Freud suggested that Hans's phobia was developed as a result of anxiety due to Oedipus complex. Hans unconsciously hated his father and wanted to kill him and possess his mother. This led to a fear in Hans that his father would kill or castrate him for having such negative feelings. Since these unconscious conflicting thoughts were not acceptable to the conscious mind, the anxiety created was displaced on 2 horses as these symbolically represented his father. This explanation was criticized as being far too speculative by many researchers, and an alternative explanation of Hans' phobia in terms of the learning theory was provided by behavioral theorists. Behavioral perspective. In the development of phobias, the behavioral theorists focus on learned behavior. Wolpe and Rachman in 1960 suggested that Hans' horse phobia originated from an instance of traumatic classical conditioning. He had witnessed an accident in which a horse was badly hurt. It upset him so much that he started to avoid leaving the house so as not to encounter the horses in the street. Several research studies by other theorists also supported the role of classical conditioning principles in acquisition of phobias. An individual learns to fear a previously neutral stimulus which is paired with a noxious object or event. Once a phobia is acquired, it gets generalized to similar objects or events. In a survey conducted by Oz and Hugdal, 58% of the respondents attributed their phobia to a traumatic conditioning situation. Further, direct conditioning may be especially common in the onset of dental phobia, claustrophobia, and accident phobia. Vicarious or observational learning. Phobias can be acquired by merely observing another person who acts fearfully to a given object or situation. For example, lab-reared rhesus monkeys who were not initially afraid of snakes rapidly developed phobia of snakes after observing their wild-reared counterparts behaving fearfully with snakes. Similar observations were reported when lab-reared monkeys watched the videotape of wild-reared monkeys behaving fearfully with snakes. This implies that phobias can be developed through mass media also. This involves informational learning where an individual learns to fear a particular object or situation by hearing or reading that the situation is dangerous. For example, learning to fear flying by hearing about plane crashes in the news, or learning to fear driving by continually receiving warnings from others that driving is dangerous. Cognitive perspective. Cognitive factors, such as attention, memory, cognitive biases help to maintain the phobias that have been acquired. Generally, people with specific phobias tend to pay more attention to threatening information that relates to their fear. For example, individuals with spider phobias are often the first people to spot a spider if there is one in the room. People with phobias also tend to have distortions in their memories for encounters with the objects and situations they fear. For example, people with an animal phobia may remember the animal that they have encountered as larger, faster, or more frightening than it was. Further, people with specific phobias tend to hold beliefs and to interpret situations in such a way as to maintain or increase their anxiety. For example, people with a fear of height may assume that they are more likely to fall. People who fear enclosed places, such as elevators, may believe that they will run out of air, or that they will be unable to escape. Lastly, avoidance of feared situations prevents people with specific phobias from learning that the situations they fear are not as dangerous as they feel. In addition, relying on safety behaviors, for example, driving extra slowly to avoid an accident, always wearing shoes to prevent insects from touching one's feet, can also help to maintain a person's fears. 3. Evolutionary perspective. Our evolutionary history has affected which stimuli are likely to be feared. For example, snakes, water, heights, enclosed spaces are more likely to be objects of fear than bicycles, knives, cars, even though the latter objects may be at least as likely to be associated with trauma. Primates and humans have a biological preparedness to rapidly associate certain kinds of objects such as snakes, spiders, water and enclosed spaces with aversive events. It has been suggested that this preparedness may have been a selective advantage, for example, helped in survival, for our ancestors in the course of evolution. Oman has provided 2 lines of evidence to support the preparedness theory of phobias. First, In case of human participants, fear was conditioned more effectively to fear relevant stimuli such as snakes and spiders than to fear irrelevant stimuli such as flowers and vegetables. In case of primates, lab-reared monkeys with no prior experience to fear relevant stimuli also showed conditioning for fearing relevant than irrelevant stimuli. Treatment of phobia. The main treatment options for phobia are as follows. 1. Exposure therapy. The client is exposed to the feared object, animal, or place in a controlled environment. There are various forms of the exposure therapy, for example, systematic desensitization, flooding, virtual reality. Systematic desensitization is based on the premise that one cannot be anxious and relaxed at the same time. It is conducted in several steps. Firstly, with the help of client, a hierarchy of the fear-eliciting situation is formed, beginning from the least fear-producing to the most fear-producing situation, for example, dog barking in the next lane to the dog barking just in front of the client. Secondly, the client is taught relaxation exercises, such as progressive muscle relaxation, deep breathing. Then the person is asked to relax and imagine the fear-producing situation in the ascending order of the hierarchy, beginning from the least fear-producing situation. Gradually, the client learns to relax in the most fear-producing situation, thereby extinguishing phobia. An opposite of this technique is flooding, where the client is exposed to the most fear-producing situation and is taught that he/she can go through the fear-producing situation without being harmed, contrary to his/her expectation of getting hurt. Earlier therapists used the real situations or imagination, if the situation was hazardous, whereas now therapists use virtual reality. In this type of therapy, the therapists with the help of computers and other equipment simulate the fear-producing situation, for example, heights, air travel, and the client is exposed to the simulation exercise. Through all these techniques, the client realizes the irrationality of his/her fear and thus the fear gets extinct. 2. Modeling. Based on Bandura's vicarious learning theory, the client either observes another person, sometimes the therapist, in real life or in a movie, acting fearlessly in a situation that causes phobia in the client. By watching another person acting fearlessly and calmly, the client also learns that the phobic situation or the stimulus is harmless, which helps to treat phobia. While the behavior therapies have been found to be effective in treating phobia, medication and cognitive techniques, such as cognitive restructuring, have not been found to be effective. According to the recent findings, a drug, called D-cycloserine, when used in conjunction with exposure therapies like virtual reality, has been found to increase the effectiveness of exposure therapies. 8.4 Social anxiety disorder, clinical features, causes and treatment. Clinical features. Social anxiety disorder, SAD, is also called as social phobia, which is a persistent, irrational fear generally linked to the presence of other people and can be extremely debilitating. However, the difference between social phobia and social anxiety disorder is largely chronological, in that social phobia is the former term and SAD is the current term for the disorder. The official psychiatric diagnosis of social phobia was introduced in the third edition of the Diagnostic and Statistical Manual, DSM-3. Social phobia was described as a fear of performance situations and did not include fears of less formal situations such as casual conversations. DSM-5 describes social anxiety disorder as disabling fears of one or more specific social situations, such as public speaking, urinating in a public bathroom, or eating or writing in public, where the person fears of being exposed to the scrutiny and potential negative evaluation of others, or that one may act in an embarrassing or humiliating manner. Therefore, the person tries to avoid such social situations, or when avoidance is not possible, endures them with great distress. There are two subtypes of SAD according to DSM-5. One is specific to performance situations, for example, public speaking, and the other is general or in non-performance situations, for example, eating in public. Selective mutism can be considered as one variant of social anxiety disorder. Mostly seen in children, selective mutism involves the inability of the child to speak in specific situations, whereas he is able to speak normally in other situations. For example, while the child speaks well at home, she fails to verbalize at school because of experiencing higher levels of social anxiety. They fail to communicate in selective situations / contexts despite the ability to speak in other situations. Box 8.2 Criteria for social anxiety disorder according to DSM-5. A remarked or persistent fear of one or more social or performance situations in which the person is exposed to unfamiliar people or to possible scrutiny by others. The individual fears that he or she will act in a way, or show anxiety symptoms, that will be humiliating or embarrassing. Note, in children, there must be evidence of the capacity for age-appropriate social relationships with familiar people, and the anxiety must occur in peer settings, not just in interactions with adults. Exposure to the feared social situation almost invariably provokes anxiety, which may take the form of a situationally bound or situationally predisposed panic attack. Note, in children, the anxiety may be expressed by crying, tantrums, freezing, or shrinking from social situations with unfamiliar people. C. The person recognizes that the fear is excessive or unreasonable. Note, in children, this feature may be absent. D. The feared social or performance situations are avoided or else are endured with intense anxiety or distress. E. The avoidance, anxious anticipation, or distress in the feared social or performance situation, interferes significantly with the person's normal routine, occupational, academic, functioning, or social activities or relationships, or there is marked distress about having the phobia. In individuals under age 18 years, the duration is at least 6 months. G. The fear or avoidance is not due to the direct physiological effects of a substance, for example, a drug of abuse, a medication, or a general medical condition, and is not better accounted for by another mental disorder, for example, panic disorder with or without agoraphobia, separation anxiety disorder, body dysmorphic disorder, a pervasive developmental disorder, or schizoid personality disorder. If a general medical condition or another mental disorder is present, the fear in criterion is unrelated to it. For example, the fear is not of stuttering, trembling in Parkinson's disease, or exhibiting abnormal eating behavior in anorexia nervosa or bulimia nervosa. Comorbidity. People who suffer from SAD are also likely to suffer from one or more anxiety disorders and depressive disorder. Generalized SAD has been found to be comorbid with depression and alcohol abuse. Specific SAD is comorbid with GAD, specific phobias, panic disorder, avoidant personality disorder, mood disorders and alcohol abuse. Prevalence, age of onset, gender differences and cultural factors. SAD is common and found even in public celebrities, for example, Barbara Streisand, American actor and singer. Its lifetime prevalence is 12% of a given population. In India, prevalence rate of 12.8% has been found in the adolescents. It is a persistent disorder with spontaneous recovery shown by only 37% of the sufferers over 12 years. SAD usually begins during early or middle adolescence or early adulthood. SAD is more common among women than men, as 60% of the women have been reported to suffer from the disorder. SAD is also affected by cultural factors. Example, in Japan, fear of giving offense to others is very important, whereas in USA, fear of being negatively evaluated by others is a source of social anxiety. General characteristics of people with SAD. The individual usually tries to avoid situations in which she/he might be evaluated and reveal signs of anxiousness or behave in an embarrassing way. Fears concerning excessive sweating or blushing are common. Speaking, performing in public, eating in public, using public lavatories, etc. can elicit extreme anxiety, and they often work in occupations or professions far below their talent or intelligence because their extreme social sensitivity does not allow them to work in situations which involve interactions with people. Social anxiety disorder is different from separate anxiety disorder. Separation anxiety disorder is mostly seen in children and to some extent in adolescents and even in adults. It involves a fear of separation from the caregiver or major attachment figures. The child experiences distress when not around the caregiver and is concerned that they would be alone if something happens to their caregiver. Instances of refusal to go outside the home or to the school alone is normal in very small children, but they usually outgrow it and develop independence. However, those who develop clinical levels of fear and anxiety related to separation from their caregiver can have separation anxiety disorder. They may also experience nightmares related to separation and exhibit symptoms of headache or stomach pain. Causes of social anxiety disorder. Let us understand the causal factors for social anxiety disorder. 1. Biological perspective. Genetic and temperamental factors. Results from a very large study of female twins suggests a variance of 30% due to genetic component in development of SAD. Family studies also show that first-degree relatives of probands were more than 2 to 3 times as likely to also share a diagnosis. Further, infants easily distressed by unfamiliar stimuli are at an increased risk for becoming fearful during childhood, and by adolescence, show increased risk of developing social phobia. 2. Psychological perspective. Behavioral explanation. SAD in many cases is a result of direct or vicarious classical conditioning. In a study, 56% of people with specific SAD and 44% with generalized SAD reported direct traumatic conditioning experiences. People with generalized SAD may be especially likely to have grown up with parents who were socially isolated or who devalued sociability, thus providing ample opportunity for vicarious learning. Also, many people with social phobia reported to develop it while having problems in fitting in within their peer group. Cognitive factors. Socially anxious people are more concerned about evaluation than people who are not anxious and are more aware of the image they present to others. They tend to view themselves negatively even when they have actually performed well in social interactions. In a study by Davison and Zylboim which used articulated thoughts in simulated situations, it was reported that people with social phobia showed more negative articulated thoughts in a stressful situation in comparison to people without social phobia. Persistent and irrational fears actually occurs because fear is elicited through early automatic processes that are not available to conscious awareness. After this initial processing, the stimulus is avoided, so it is not processed fully enough to allow the fear to extinguish. Social skills deficit model. According to this model, inappropriate behavior or a lack of social skills is the cause of social anxiety. The individual has not learned how to behave so that he/she feels comfortable with others. The person repeatedly commits faux pas, tactless mistake. Person is awkward and socially inept, often criticized by social companions. Support for this model comes from findings that socially anxious people are indeed rated as being low in social skills. perception of uncontrollability and unpredictability, submissive and unassertive behavior which is a characteristic feature of people with social phobia is a result of uncontrollability and unpredictability in life situations. People with social phobia have a diminished sense of personal control over events in their lives. 3. Evolutionary perspective. According to Oman et al., 1985, social phobias may have developed as a byproduct of dominance hierarchies. Aggressive encounters between members of a social group establish dominance hierarchies where a defeated individual usually displays fear and submissive behavior but rarely escapes from the situation. Thus, people with social phobia are more likely to endure being in the feared situation than to run away. Perhaps, social phobias develop mostly in adolescence and early adulthood when dominance conflicts are most prominent. Preparedness and social phobia. Oman and colleagues have suggested that we humans may have an evolutionary-based predisposition to acquire fears of social stimuli that signal dominance and aggression, for example, anger or contempt, from other humans. The researchers have reported that participants develop stronger conditioned responses when slides of angry faces are paired with mild electric shock than when happy or neutral faces are paired with the same shocks. Further, even very brief presentations of the angry face that are not consciously perceived are sufficient to activate the conditioned responses. Treatment of social phobia. Main treatment options used by people for social phobia are 1. Cognitive behavioral therapy. Cognitive restructuring along with behavioral techniques has been proved to be more effective as compared to lone use of behavioral therapy. The distorted cognitions of client that lead to social phobia, such as, nobody likes me, people do not find me attractive are identified and the therapist helps the client to restructure such negative cognitions through reanalysis. During the reanalysis, the client is educated about the origin of cognitive distortions, the automatic negative thoughts and how these affect the client's social behavior and restructuring such thoughts by cognitive techniques, for example, questioning the validity of such negative thoughts, taking negative thoughts as hypotheses and logically testing those hypotheses. The clients are also encouraged to do exercises where they are taught to shift their focus from self to others and the situations. Videotaping their social interactions has also been successfully used as a feedback mechanism. 2. Medications. Research has also shown that medications such as antidepressants, for example, monoamine oxidase inhibitors, or MAOIs and selective serotonin reuptake inhibitors, or SSRIs, have been proved to be effective treatment for social phobia. However, further comparative research in this area has reported the cognitive behavior therapy to be more effective than the medications as it does not involve side effects and relapse rates are also low. Lastly, researchers such as Guaisella et al. Have reported that a medication, named D-cycloserine taken in conjunction with cognitive behavior therapy led to faster rates of successful treatment. 8.5 Panic disorder, clinical features, causes and treatment. Clinical features. DSM-5 defines a panic attack as a discrete period of intense fear or discomfort, in which at least 4 from a list of 13 standard symptoms develop abruptly and reach a peak within 10 minutes. Although the symptoms must peak within 10 minutes, the attacks often peak within a few seconds and the symptoms gradually subside over a period lasting from a few minutes to about half an hour. Box 8.3 Criteria for panic disorder according to DSM-5. A recurrent unexpected panic attacks. A panic attack is an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes, and during which time 4 or more of the following symptoms occur. Note, the abrupt surge can occur from a calm state or an anxious state. 1. Palpitations, pounding heart, or accelerated heart rate. 2. Sweating. 3. Trembling or shaking. 4. Sensations of shortness of breath or smothering. 5. Feelings of choking. 6. Chest pain or discomfort. 7. Nausea or abdominal distress. 8. Feeling dizzy, unsteady, light-headed, or faint. 9. Chills or heat sensations. 10. Paresthesias, numbness or tingling sensations. 11. Derealization, feelings of unreality, or depersonalization, being detached from oneself. 12. Fear of losing control or going crazy. 13. Fear of dying. Note: culture-specific symptoms, for example, tinnitus, neck soreness, headache, uncontrollable screaming or crying, may be seen. Such symptoms should not count as one of the 4 required symptoms. B. At least one of the attacks has been followed by 1 month, or more, of one or both of the following: 1. Persistent concern or worry about additional panic attacks or their consequences, for example, losing control, having a heart attack, going crazy. 2. A significant maladaptive change in behavior related to the attacks, for example, behaviors designed to avoid having panic attacks, such as avoidance of exercise or unfamiliar situations. C. The disturbance is not attributable to the physiological effects of a substance, for example, a drug of abuse, a medication, or another medical condition, for example, hypothyroidism, cardiopulmonary disorders. D. The disturbance is not better explained by another mental disorder, for example, the panic attacks do not occur only in response to feared social situations, as in social anxiety disorder, in response to circumscribed phobic objects or situations, as in specific phobia, in response to obsessions, as in obsessive-compulsive disorder, in response to reminders of traumatic events, as in post-traumatic stress disorder, or in response to separation from attachment figures, as in separation anxiety disorder. It is clear from the above list that out of 13, majority, 1 to 10, of the symptoms are physical, whereas only last 3 are cognitive symptoms. In addition to these symptoms, panic attacks may be accompanied by other symptoms as well, for example, blurred vision. Panic attacks are experienced across all the anxiety disorders, triggered by a feared situation object /situation /thought /worry. Many people without an anxiety disorder may experience panic attacks from time to time, for example, when giving a formal presentation or taking an exam, or upon encountering some other stressful situation. Panic attacks occur frequently in the general population, with some studies showing that up to a third of individuals experience a panic attack during a given year. Unlike most panic attacks, which are typically triggered by stress, worries, or feared situations, the panic attacks that occur in panic disorder often occur out of the blue, without any obvious trigger or cause. Types of panic attacks. Acute or situationally predisposed panic attacks. Panic attacks linked to specific situations such as driving a car. They are strongly associated with situational triggers. Uncued panic attacks. Attacks may occur in unexpected or benign states or in the absence of any provocation, for example, in sleep, which is known as nocturnal panic. In case of some people, panic disorder may lead to agoraphobia. In DSM-5, panic disorder is diagnosed as with or without agoraphobia. The term agoraphobia comes from the Greek word agora, which means market, hence it means a fear of the marketplace. Though it implies a fear of open spaces, however, people having agoraphobia are much more fearful of enclosed spaces, such as tunnels, small rooms, and elevators. Some people with panic disorder develop a concern that they will not be able to make an exit from a crowded place if they have a panic attack. Hence, they avoid going to places where they believe that their escape would be difficult in an emergency, i.e., panic attack, and it would cause embarrassment to them. At first, people avoid those situations where they developed agoraphobia, but soon it gets generalized and they begin to avoid not only places outside home, such as market, elevators, public transport, but sometimes places within home also, for example, attic, terrace, which they believe would be difficult to escape from. Most but not all people with panic disorder develop at least some degree of agoraphobia. In extreme cases, an individual with panic disorder and agoraphobia may not leave the house at all. Usually people with agoraphobia are able to leave the house, if someone they know accompanies them whom they believe will be able to help them in making a safe exit in case of a panic attack. Comorbidity: many people, 83% approximately, suffering from panic disorder with or without agoraphobia also have some other psychological disorder such as GAD, specific phobia, social phobia, depression, substance use disorder, such as smoking and alcohol consumption, and avoidant personality disorder. Prevalence, gender differences and age of onset. Lifetime prevalence for panic disorder with or without agoraphobia has been reported to be 4.7%, but panic disorder without agoraphobia is more prevalent. Prevalence varies cross-culturally. For example, in Africa, it was diagnosed in about 1% of men and 6% of women. In Taiwan, prevalence is quite low, perhaps because of a stigma about reporting a mental problem. Among the Eskimo of West Greenland, for example, kayak angst occurs in seal hunters who are alone at sea. Attacks involve intense fear, disorientation, and concerns about drowning. Panic disorder with and without agoraphobia is more prevalent in women than in men, with a prevalence of 5% and 2%, respectively. Kessler, Q. et al., 2005 c. About 80 to 90% of patients with agoraphobia are reported to be women. However, evidence has been found that men with agoraphobia often indulge in self-medication with nicotine and alcohol to endure panic attacks and often do not develop avoidance behavior, as has been found in agoraphobia. Panic disorder is a debilitating disorder. Though its symptoms may increase or decrease at times, however, it has a chronic course. Recovery may take a long time, 12 years as reported in a longitudinal study, with recurrence in 58% of the patients. The age of onset has been found to be 23 to 34 years on an average. For women it usually starts in 30s or 40s. Its onset is associated with stressful life experiences. Causes of panic disorder. The causes of panic disorder involves the interplay of many factors. 1. Biological perspective. Genetic variables. Family and twin studies have pointed toward a genetic component in the development of panic disorder. Kendall et al. Reported a variance of 33 to 43% due to genetic factors in a large twin study that analyzed the factors for inheritability of panic disorder. Like other anxiety disorders, people with neuroticism are more likely to develop panic disorder. Recently, researchers have attempted to find specific genes that are responsible for inheriting panic disorder. However, Strug et al. 2010, Clark et al. 2010, found no unequivocal results. Brain activity. Earlier theories suggested the role of locus coeruleus, LC, in the brain stem and norepinephrine, a neurotransmitter particularly involved in the activity of LC in causing panic attacks. Stimulation of this area in the monkeys causes a panic attack. Hence, it was suggested that naturally occurring attacks might be due to overactivation of norepinephrine in LC. Research with humans also found that yohimbine, a drug that stimulates activity in LC could elicit panic attack in patients with panic disorder. However, more recent research is not consistent with this position. For example, drugs that block firing in the LC were unable to treat patients with panic disorder. Later research found that an overactive amygdala rather than LC is implicated in panic disorder. Amygdala, consisting of a group of nuclei, is located in front of the hippocampus in the limbic system, and its role in emotion of fear has been established through empirical research. Stimulation of amygdala stimulates LC and other autonomic responses occurring during panic attack. Amygdala is said to be at the center of the fear network and is connected to the lower brain areas like LC as well as higher cortical areas like prefrontal cortex. Hence, panic attacks may occur either due to stimulation of lower or higher areas of brain. Dysfunctional biochemistry. Klein and Sheehan hypothesized that biochemical dysfunctions lead to panic attacks, which are the alarm reactions. For more than 2 decades, this hypothesis was supported by several studies. These studies showed that in comparison to normative group, when people with panic disorder are exposed to panic provocation procedure, they are more likely to suffer from panic attacks. The panic provocation procedure involves exposure to biological challenges, such as inhaling air with higher than normal level of carbon dioxide, taking large amounts of caffeine, infusing sodium lactate into the body, to induce intense physical symptoms such as palpitations, high blood pressure and hyperventilation that is likely to evoke a panic attack. The noradrenergic and serotonergic systems are known to be involved in panic attacks. The noradrenergic system gets activated due to stress and in turn leads to cardiovascular symptoms which provoke panic attack. On the other hand, serotonergic system's activation decreases the noradrenergic activity. This has been supported by the medication results, as drugs used for treatment of panic disorder not only decrease the noradrenergic activity, but it also increases the serotonergic activity. Another neurotransmitter, GABA, which has an inhibitory effect on anxiety, has also been found to be abnormally low in people with panic disorder. Thus, such people suffer from anxiety in anticipation of suffering from another panic attack. 2. Psychological perspective. Behavioral factors. Several researchers have suggested that a comprehensive learning theory can account for the development of panic disorder. Goldstein and Chambliss have studied the effect of interoceptive, internal to body, and exteroceptive, external to body, stimuli in conditioning of panic disorder. Through classical conditioning, interoceptive cues like heart palpitations, stomach ache, and exteroceptive cues such as a place or presence of specific people that were present during the initial panic attack, gets associated with it and later on act as triggers for anxiety about future panic attacks. In simple words, people end up developing a panic about a panic attack. This also explains the agoraphobic avoidance of places like markets or shopping malls, as these serve as exteroceptive cues for an oncoming panic attack. Inhibitory learning, which is required for extinction of a conditioned response, has been suggested to be impaired in panic disorder. Thus, people with panic disorder are unable to learn to discriminate the conditioned stimulus as a safety cue. However, panic attacks sometimes seem to be uncued, i.e., no trigger, internal or external, seems to be present before the panic attack. This is because panic attack in some cases result from the internal cues that are unconsciously experienced by the individual. This can be understood with an example of a person frightened of a racing heart and who, while feeling happy and excited, gets a panic attack and is unable to understand the reason of it as he/she was happy. The panic attack in this case occurred because while feeling happy and excited the person's heart raced, which served as a cue, though not in awareness of that person, for the panic attack. Cognitive factors. People with panic disorder have hypersensitivity for their bodily sensations, which are interpreted by them as a sign of an impending panic attack. The tendency to interpret bodily sensations as a sign of impending catastrophe, such as a heart attack, tumors, etc., has been called catastrophizing by Clark. Such frightening thoughts start the vicious cycle as it increases the already present physical symptoms of anxiety, which in turn increase the catastrophic thoughts, which in turn triggers the panic attack. It should be noted that the person may be unaware about catastrophizing, as these thoughts are out of consciousness. BAPCH has called these thoughts as automatic thoughts, which actually trigger the panic attack. However, the cause of developing catastrophizing thoughts is not known. Nevertheless, only those people who have a tendency for catastrophizing develop panic disorder. Evidence has been found in line with this theory. For example, Clark and Teichmann et al. Have reported that individuals with panic disorder have a greater tendency to catastrophize their bodily sensations. This cognitive theory of panic disorder also predicts that the panic can be reduced or prevented by changing people's cognitions about their bodily sensations. Further, likelihood of panic attacks was significantly reduced when people suffering from panic disorder were given a detailed explanation of what physical symptoms to expect when injected with sodium lactate in a panic provocation study. Both learning and cognitive theories provide explanations about panic attack. However, the main difference between the two theories is the emphasis that the cognitive theory puts on the meaning that people with panic disorder give to their bodily sensations. Such interpretation of bodily sensations is not necessary for conditioning, as the interceptive or exteceptive stimuli could be outside the realm of awareness. In the light of this difference, learning theory is better able to account for uncued panic attacks as well as panic attacks while sleeping, as both occur in the absence of automatic cognitions. Anxiety sensitivity and perceived control. Several explanations have been provided that can find support in both learning and cognitive perspectives. For example, McNally and Pagara et al. Found that people with hypersensitivity to anxiety are more likely to develop panic attacks and subsequently panic disorder. Interestingly, some studies have also shown the role of perceived control in reduction and even prevention of panic attacks. For example, in a panic provocation study, if a person has a control over inhalation of carbon dioxide, inhalation of CO2 is known to bring on panic. The possibility of suffering from a panic attack is reduced significantly or even blocked. Further, Bentley et al. Have shown that anxiety sensitivity interacts with perceived control for the development of panic attack, i.e., lower the perceived control, greater was the effect of anxiety effect on panic disorder. Lastly, higher the perceived control over emotions and threatening situations, lower was the agoraphobic avoidance as the person feels in control of the situation. Safety behaviors and the persistence of panic. Panic disorder once developed is maintained despite contrary evidence. That is, someone who has always suffered from a panic attack about having a heart attack on finding his /her heart racing but never actually had a heart attack should understand that a racing heart does not lead to a heart attack. But this logic does not prevent a panic attack, because each time the person was apprehending a heart attack he/she indulged in a safety behavior like slow breathing and believed that this safety behavior prevented the heart attack. Thus, the safety behaviors maintain the panic disorder. Thus, people with panic disorder should be persuaded to abandon the safety behaviors so that they could realize that their indulgence in safety behaviors does not prevent the heart attack or any other impending fatality like fainting. Research suggests that dropping of safety behaviors by people with panic disorder increased the effectiveness of the treatment. Cognitive biases and the maintenance of panic. People with panic disorder have a tendency for processing the threatening information in a biased manner. For example, such people interpret the ambiguous bodily sensations as well as other ambiguous situations as more threatening than the people in the control group. Also, such people have a biased attention also as they focus more on the threatening information, such as words indicating panic like palpitations, numbness, fainting etc. fMRI studies have shown greater activation of memory areas that are involved in processing information about threatening stimuli in people with panic disorder than the normative group. However, the role of biased information processing as a cause or as a symptom of panic disorder remains unclear. Overall, it can be concluded that both biological and psychosocial factors have been found to play a role in the development of panic disorder, and neither of the two in isolation can explain its development. Treatment of panic disorder. The approaches to treatment of panic disorder are as follows. 1. Exposure therapy. As explained in the above section on phobias, exposure therapy for agoraphobia and panic involves exposing the client to the feared situation for a long period of time, often in the presence of the therapist or a family member. The underlying idea is that the client, on being exposed to the feared situation for a long time without eliciting any harmful effects, help him/her to realize the futility of his/her agoraphobia with panic attacks. This exercise has been shown to be effective in treating 60 to 75% of people with agoraphobia and a maintenance rate of 2 to 4 years. A limitation of this therapy was that it did not deal with panic disorder specifically. Hence, another technique, known as interceptive exposure, was devised to deal with panic attacks in 1980s. This technique involves causing internal bodily sensations such as spinning head, nausea, breathlessness, which are associated with panic attacks, with the help of activities like seating a client in a spinning or rocking chair. When the client undergoes a prolonged exposure to such situations without getting a panic attack, the association of the internal bodily cues to panic attacks gets extinct. 2. Integrative technique. Cognitive restructuring integrated with exposure therapy used specifically to treat panic disorder is known as panic control treatment. It involves educating the client about the role of catastrophic automatic thoughts in causing and maintaining the panic disorder. During the therapy, the client is taught to identify the negative automatic thoughts and dispute those in a logical manner, using techniques like hypotheses testing and humor. Then the client is exposed to the panic-eliciting situations, both internal bodily sensations and external cues, to develop tolerance against the discomfort caused by such situations. This helps the client to deal with panic-causing situations efficiently. Research evidence has shown the integrative technique to be more effective than using either the exposure or cognitive restructuring technique alone. It has proven to be effective in 70–90% of clients, and maintenance rate of 1 to 2 years has also been reported. 3. Medications. Medicines like anxiolytics, anti-anxiety drugs, and antidepressants have also shown to be effective in treating agoraphobia and panic. Researchers, however, conclude that both drugs have advantages and disadvantages also. Anxiolytics, which belong to the category of benzodiazepines, include drugs like alprazolam or clonazepam, which have been shown to treat acute episodes of extreme anxiety, as these drugs work quickly, within 30–60 minutes. However, these also have side effects such as drowsiness, sedation, impaired cognitive as well as motor performance. Additionally, physiological dependence may also develop because of prolonged use and lead to withdrawal symptoms like sleep disturbance, dizziness and panic attacks. Relapse rate is also quite high. Antidepressants including tricyclics, SSRIs and SNRIs, serotonin norepinephrine reuptake inhibitors, used for treating panic disorder and agoraphobia, also have advantages and disadvantages in comparison to anxiolytics. Some advantages of antidepressants are that these treat the comorbid depression and do not lead to physiological dependence. However, a disadvantage of antidepressants is that in comparison to anxiolytics, these take longer time, approximate 4 weeks, to act, hence, cannot be used in acute cases of panic disorder. Other side effects include dry mouth, severe constipation, blurred vision, etc. Lastly, relapse rates are quite high when discontinued. Though a combination of cognitive behavior therapy and medication therapy has found to be slightly more effective. However, it has been found that once the medication is discontinued, relapse is common, as perhaps many of the clients attribute their treatment gains to medication. Nevertheless, a drug named D-xyluzarine used in combination of CBT has shown promising results. 8.6 Generalized anxiety disorder, clinical features, causes and treatment. Clinical features. Generalized anxiety disorder, GAD, is a state of chronic, excessive and unreasonable worry about multiple life events or activities. Since anxiety is not anchored to a specific object or situation as in phobias, it was earlier described as free-floating anxiety. Individual with GAD is persistently anxious often about minor things, and worry chronically. People with GAD spend a great deal of time worrying about a wide range of topics and describe their worrying as uncontrollable. The clinical features of GAD, as per DSM-5, is given below in Box 8.4. Box 8.4, DSM-5 Criteria for Generalized Anxiety Disorder. A excessive anxiety and worry, apprehensive expectation, occurring more days than not for a period of at least 6 months, about a number of events or activities, such as work or school performance. B. The person finds it difficult to control the worry. C. The anxiety and worry are associated with 3, or more, of the following 6 symptoms, with at least some symptoms present for more days than not for the past 6 months. Note: only one item is required in children. 1. Restlessness or feeling keyed up or on edge. 2. Being easily fatigued. 3. Difficulty concentrating or mind going blank. 4. Irritability. 5. Muscle tension. 6. Sleep disturbances, difficulty falling or staying asleep, or restless unsatisfying sleep. D. The focus of the anxiety and worry is not confined to features of an axis I disorder. For example, the anxiety or worry is not about having a panic attack, as in panic disorder, being embarrassed in public, as in social phobia, being contaminated, as in obsessive compulsive disorder, gaining weight, as in anorexia nervosa, having multiple physical complaints, as in somatization disorder, or having a serious illness, as in hypochondriasis, and the anxiety and worry do not occur exclusively during post-traumatic stress disorder. The anxiety, worry, or physical symptoms cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. If the disturbance is not due to the direct physiological effects of a substance, for example, a drug of abuse, a medication, or a general medical condition, for example, hypothyroidism, and does not occur exclusively during a mood disorder, a psychotic disorder, or a pervasive developmental disorder. Note: no changes were made from DSM-4 to DSM-5. Comorbidity GAD is associated with functional impairment and increased risk of adverse health outcomes, including cardiovascular disease and suicide. It is also frequently found in conjunction with other psychiatric conditions, including depression, panic disorder, post-traumatic stress disorder, and social phobia. Prevalence: GAD is common, with a prevalence rate of 3% for a period of any one given year and a lifetime prevalence of 5.7%. Lifetime prevalence in India is 5.8%. Age of onset: nearly 60 to 80% people with GAD report that they have been anxious for as long as they remember, whereas many others have reported a slow and insidious onset. It is difficult to determine the age of onset, but research has suggested that older adults often develop it, and it is the most common anxiety disorder for them. Cause: GAD is a chronic disorder. A 12-year follow-up study reported that 42% of the people diagnosed with GAD did not remit even after 13 years, and nearly 50% of those who remitted had a recurrence. Though it tends to disappear after age 50 for many people, it is usually replaced by somatic symptoms disorder with physical health concerns. It is a common and a chronic disorder. However, in spite of high levels of worry and perceived low well-being, most of the people with GAD manage their lives, though with some role impairment. As compared to panic disorder or major depressive disorder, which are more debilitating disorders, people with GAD are less likely to avail the psychological treatment facilities, because they usually visit physicians with physical complaints like muscle ache, gastrointestinal problems, etc. Gender ratio: GAD is twice as common in women as in men. General characteristics of people with GAD. People suffering from GAD live in a relatively constant state of diffuse uneasiness, tension, and worry. They are almost always in an anxious apprehension, defined as a future-oriented mood state in which a person constantly attempts to be ready to deal with any upcoming negative events. There is chronic over-arousal along with high levels of negative affect, and a sense of uncontrollability. Decision-making is difficult as they have poor concentration and dread to make mistakes. They often unsuccessfully attempt to avoid anxiety by procrastinating or indulging in checking activities. They are hypervigilant for all possible signs of threat in their environment. There are frequent complaints of muscle tension and aches in the neck and upper shoulder region. Sleep disturbances, such as insomnia, nightmares, and sometimes hypersomnia, excessive sleep, to escape from anxiety, are often reported. Such people feel upset, uneasy, and discouraged due to constant worries. Family, finances, work, and personal illness were found to be the most common life areas of worry. Decision-making is difficult for them, and they worry endlessly over possible errors that they might have made while deciding. Real and imagined mistakes committed currently or in the past are often reviewed after going to bed. All the possible future difficulties are anticipated by them. They are unable to logically think that it is useless to trouble oneself with future outcomes which are beyond one's control. Failure to control their tendency to worry gives them a feeling of helplessness. Causes of GAD. 1. Biological perspective. Genetic factors. There is mixed evidence for genetic factors, however, a modest genetic component for GAD has been reported. Among the research studies carried out so far, one of the largest and most recent twin studies has reported a variance of 15 to 20% in liability to GAD due to genetic component. In other words, there is higher concordance rate for GAD in MZ than DZ twins. Further, strong evidence has been found for a common underlying genetic predisposition for GAD and major depressive disorder, MDD. Nevertheless, whether a person with a genetic risk for GAD or MDD will develop the disorder /S is determined by the environmental factors, non-shared environment. A basic personality trait called neuroticism has been conceptualized as the common underlying predisposition for developing GAD and MDD. Neurochemical and neurohormonal factors. Neurobiological model is based on the research conducted between 1950s and 1970s on the operations of benzodiazepines, a group of drugs that are effective in the treatment of anxiety. Researchers discovered a receptor in the brain for benzodiazepines that is linked to the inhibitory neurotransmitter, gamma-aminobutyric acid or GABA. In normal fear reactions, neurons throughout the brain fire and create the experience of anxiety. This neural firing also stimulates GABA system, which inhibits this activity and reduces anxiety. GAD may result from some defect in the GABA system so that anxiety is not brought under control. The benzodiazepines may reduce anxiety by enhancing the release of GABA. GABA, serotonin and norepinephrine have been suggested to play a role in anxiety, but their interaction remains largely unknown till date. The corticotropin-releasing hormone, CRH. The CRH plays a role in GAD as it is an anxiety-producing hormone. When CRH is activated by stress or perceived threat, it stimulates the pituitary gland, which in turn releases the adrenocorticotropic hormone, ACTH. The ACTH stimulates the adrenal gland, which in turn releases the stress hormone called cortisol. The CRH is believed to play an important role in GAD as it has been discovered to affect the bed nucleus of the extension of amygdala, which mediates generalized anxiety. 2. Psychoanalytic perspective. Generalized anxiety is the result of a constant unconscious struggle between ID impulses and ego. ID impulses are aggressive and sexual in nature, and struggle for expression, whereas the ego, because of its unconscious fear of being punished, does not let ID express its desires. Since the source of anxiety is unconscious, person does not know the reason for anxiety and as a result is always anxious and apprehensive. The person cannot evade anxiety as he/she cannot escape from ID, for escape from ID means that the person is no longer alive. Furthermore, since anxiety is not displaced onto a specific object or situation as it happens in the case of phobia, hence the person is anxious nearly all the time. But due to lack of empirical verification, this viewpoint is not clinically accepted. Behavioral perspective. According to Wolpe, the elicitors of anxiety may be environmental factors, for example, other people or social situations. A person who spends most hours of his/her day with other people may be anxious because of the people or the social situations and not because of any internal factors, i.e., the person learns to associate their anxiety with the presence of other people. Cognitive behavioral perspective. The main underlying idea is that GAD results from distorted cognitive processes. People with GAD often misperceive benign events, such as crossing the street, as involving threats, and their cognitions focus on anticipated future disasters. Their attention is easily drawn to threatening stimuli. Studies have shown that in contrast to non-anxious people, generally anxious people tend to notice threat cues when presented with a mixture of threat and non-threat cues. Furthermore, they are more inclined to interpret ambiguous stimuli as threatening and to rate ominous events as more likely to occur to them. The heightened sensitivity to threatening stimuli occurs even when the stimuli cannot be consciously perceived. Uncontrollable and unpredictable aversive events are much more stressful and hence more anxiety-provoking than the controllable and predictable events. People with GAD may have a history of experiencing many important life events as unpredictable and uncontrollable. Early experience with control and mastery can immunize to some extent against the harmful effects of exposure to stressful situations and may in turn immunize against GAD. Borkovic et al. Have proposed another cognitive view as they focused on the various functions served by worry. Worry can be negatively reinforcing. It may serve 5 positive functions for people with GAD. Superstitious avoidance of catastrophe. Worrying will lessen the likelihood of a feared event. Actual avoidance of catastrophe. Worrying helps to generate ways of avoiding catastrophe. Avoidance of deeper emotional topics. Worrying distracts from more troublesome emotions. Coping and preparation, and motivating device, helps in motivating oneself to work. A subset of people with GAD believe that worry has positive functions. which in turn helps in maintenance of high levels of anxiety. Worrying is self-sustaining as it does not produce much emotional arousal. For example, it does not produce the physiological changes that usually accompany emotion, and it blocks the processing of emotional stimuli. Despite its positive functions, worry has some negative consequences as well. Worry is not an enjoyable activity as it involves thinking about the negative catastrophic outcomes and can lead to a greater sense of anxiety and danger. According to Wells and Papageorgiou, it may lead to more intrusive thoughts as they found in a study that involved 3 groups watching a gruesome movie in 3 conditions. After watching the movie, one group was told to relax, the second group was told to imagine the events in the movie, and the third group was asked to verbally worry about the movie. It was found that people in the third group had more intrusive thoughts as compared to the other 2 groups after several days of watching the movie. Worrying also leads to more intense negative emotions. Further, there is evidence for paradoxical effect of worry also, that is, attempts to control worry leads to more intrusive thoughts which lead to a feeling of uncontrollability. This in turn leads to anxiety which further enhances worry. Thus, it leads to a vicious cycle of worry, intrusive thoughts and anxiety. Treatment of GAD. Psychological therapy and medication are used as treatment options for GAD. 1. Cognitive behavioral therapy, CBT. As has been described in the above sections, CBT uses a combination of behavioral techniques such as progressive muscle relaxation exercises, to relieve the physiological symptoms, such as breathlessness, muscle tension, and cognitive techniques, such as cognitive restructuring, for dealing with the psychological symptoms, such as anxiety, cognitive distortions, catastrophizing, etc. Though GAD has been known as one of the most difficult among anxiety disorders to treat, nevertheless, research review has found the CBT to successfully alleviate the symptoms of GAD. Interestingly, research has shown CBT to be as effective as benzodiazepines, and it has also helped to taper off long usage of medication. 2. Medications. Often, people suffering from GAD consult general practitioners, GPS, for somatic systems such as muscle aches, tingling sensations, numbness, breathlessness etc., and are prescribed benzodiazepines or anxiolytics, such as Alprax, Ristril, market names. These drugs lead to symptom relief, and are more effective in alleviation of physiological rather than psychological symptoms. But these drugs can lead to psychological and physiological dependence. Buspirone is a new drug which is more effective in alleviating psychological symptoms like anxiety and does not lead to sleepiness and psychological or physiological dependence, but it takes a longer time, 2–4 weeks, to show effect. Similarly, some antidepressants have also proved to be beneficial in treating GAD, but these also take a long time, several weeks, to show their effect. 8.7 Let us sum up. Let us now list all the major points that we have learned in this unit. Main anxiety disorders identified by DSM-5 are specific phobia, social phobia, panic disorder, and generalized anxiety disorder. A phobia is a persistent and disproportionate fear of a specific object or situation that presents little or no actual danger to a person. According to DSM-5, specific phobia, previously known as simple phobia, has 5 subtypes: animals, for example, snakes, spiders, dogs; natural environment, for example, water, heights, storms; blood injection injury, situational, bridges, tunnels; others, vomiting, choking; space phobia, where the person has a fear of falling down if he/she is away from walls or support. Phobias develop as a result of psychological, behavioral, biological, evolutionary, or cognitive factors. A social phobia is a persistent, irrational fear generally linked to the presence of other people. It can be extremely debilitating. The difference between social phobia and social anxiety disorder, SAD, is largely chronological, in that social phobia is the former term and SAD is the current term for the disorder. Panic disorders are characterized by panic attack, which are a discrete period of intense fear or discomfort, in which at least 4 from a list of 13 standard symptoms develop abruptly and reach a peak within 10 minutes. Panic attacks are experienced across all the anxiety disorders. Cognitive behavior therapy and medication is found to be effective in the treatment of panic disorder. Generalized anxiety disorder is a state of chronic, excessive and unreasonable worry about multiple life events or activities and is caused due to genetic, psychological, chemical, behavioral or cognitive causes. The corticotropin-releasing hormone plays a role in GAD as it is an anxiety-producing hormone. CBT uses a combination of behavioral techniques such as progressive muscle relaxation exercises to relieve the physiological symptoms, such as breathlessness, muscle tension and cognitive techniques, in the treatment of GAD.